Welcome to the Java Cafe, Java fam. Good morning. Welcome to the Java Cafe, Java fam.
Good morning, everybody. Good morning. Good morning. I look a little cloudy this morning. It is Tuesday, February 21st, 2023. It is the third Tuesday of the month. And as we've been doing since November of 2021, we are here through the sponsorship of the Massachusetts General Hospital Office of Equity and Community Health. And this morning, we're discussing pediatrics, children's health care, and asthma. We're going to talk about the importance of a pediatrician. How, if you have a pediatrician, that is almost automatic prevention for some childhood diseases. We know that children, and especially this week for all of you parents that have your wonderful offspring at home with you for the entire week, they may have been around other children that have germs and stuff. And so we're going to talk about that. I'm sure we're going to talk about vaccinations. We're going to talk about nutrition, things like that. We have two esteemed guests. One is a veteran. She was with us early on, if you remember, in the pandemic, talking about the impact of the pandemic and coronavirus on children, as well as there wasn't a lot around the vaccine at that time. But she's also been with us talking about other subjects related to children's health care. And so I'm first going to introduce Dr. Aisha James, who is a veteran here in your Healthy Java in the Java Cafe, and then also Dr. Garcia Cuete, who is from Massachusetts General Hospital as well. They are both pediatricians, and we're going to begin with Dr. Cuete. That's going to talk about like prevention in pediatrics and things like that, and Dr. James. But I wanted to at least allow Dr. James to say hello. She's going to be back with us in a few minutes, and then both of them, as you know, we do every episode, we answer your health-related questions. A disclaimer: neither one of these doctors have examined your children, and so they're going to give general feedback to your questions. But do me a favor real quick, hit that share button and invite others into the Java Cafe for this very important information. We understand that the pandemic raised a lot of issues around health disparities, and our children are very important when it comes to prevention. It's important to keep them healthy. And so, Dr. James, if you would greet the folks and say hello, not a introduction, but present, they know who you are, but just say hello.
Hi, Jimmy and everybody. It's really wonderful to be back, and especially with my friend and colleague, Dr. Cuete, who is amazing. And I'm going to learn from her as well today.
Thank you so much for the referral. And so, Dr. James, we're going to let you go take care of some other business as we see you're there in the office and working. And Dr. Cuete is going to talk with us about prevention when it comes to pediatrics. So we'll bring you back in just a little bit. Thank you so much. Dr. Garcia Cuete, I think I have that right. I mentioned to you that it's important to properly pronounce names. Please say hello to the audience, introduce yourself, and then we'll go into a couple of questions around why you chose pediatrics, your background, and then we'll jump into this important information that we need to get out to the community.
Yeah. Hi, Jimmy. Thank you again for having me. It's a pleasure to be here. And good morning to everyone who's watching at this time. So please send in your questions. I am a primary care pediatrician. So I have my training in general pediatrics, and I work in the outpatient setting. So currently I work at the Massachusetts General Hospital Revere Healthcare Center. So I see patients about 4 days a week. And I have about over 400 patients that I care for. Yes, it is. It is really a wonderful thing to be able to journey with families through the growth of their children and the growth of parents and caregivers themselves. In addition to my primary care work in seeing patients, I am involved in the creation of patient education materials. So really health literacy and creating handouts for families, which is a real passion of mine, and also having those translated into different languages. So really thinking about how we are reaching patients who speak different languages within our clinic.
Absolutely. And I heard a little bit of your why, but why did you choose pediatrics versus cardiology, ophthalmology, orthopedics, two of which are major revenue producers? But why? What's your why for pediatrics, Dr. Cuete?
Yeah, I think my why for pediatrics is knowing that children are where adults come from. And so thinking of the joy of prevention and also helping children reach their full potential
Yes.
is the real joy for me. I think I also love pediatrics because of the different developmental stages. There's a lot of variety in pediatrics. So the joy of being able to see a newborn baby and then a 2-year-old and then a 16-year-old, some that talk to you and some that don't talk to you. A newborn and a teenager might not talk much. Well, the newborn definitely does not talk, but I think there's a real joy in seeing the developmental stages. There's the variety, and also the complexity really of caring for a family, and not just one patient in front of you. So I think I love sciences, I love teaching, and I feel like pediatrics does that for me, really helping empower parents to take care of their children is part of that joy of constantly explaining things in layman's language and explaining things to them.
That is key. And that is one of the major tenets of this partnership, is to have information communicated sort of in layman's terms. One of the things you talked about is complexities. One of the things that we can sort of resolve quickly, and I used to work in adolescent care. When you mention the teenagers, there's this misnomer, that 18, they're not seen by a pediatrician no more. They can go to adult medicine. From your experience, and I don't know if it's a policy at MGH, but generally, do you see patients beyond 18 if they want to stay with you? Is that permissible?
Yes. So I see patients between the ages of 0 to 21 is really the age range. We do know that transitioning children to adult care can have its challenges. So we do see some patients beyond 21, depending on the circumstances. I think right now, our hope is always to transition children to adult providers, start preparing them. So we start the process earlier in adolescence so that they know what's coming and it's not something that sort of comes out of the blue. In addition, we do recognize that sometimes there might be shortages in adult providers, right? And so being able to be flexible on a case-by-case basis to think about maybe holding on to some patients for a while as they, again, try to get into healthcare in the adult setting, and knowing that sometimes those college years can be really challenging.
Absolutely.
And I think that one of the things that's beautiful about primary care and that continuity of care is that attachment, right? And that relationship that you build, and it can be hard to separate, but it's important to start the process early. And so transitioning of care is an aspect of what we do in preventive medicine, is starting to have those discussions, taking the adolescent out to have one-on-one conversations. So keeping the adolescent in the room and then having maybe the parent or caregiver step out so that we start to practice that one-on-one care, how to navigate the healthcare system. Because again, that can be a real place where we lose people to what preventive care is, especially if they're healthy and have no other reason to come to the doctor, right? Just to build those habits that you do go to the doctor even when you're feeling well. Just again, to have those screenings, to have the maintenance, health maintenance, and all of that to really build those habits during their childhood years.
Absolutely. And let's stay right in that vein. And so we're talking pediatrics, we're talking better healthcare for children. What is pediatric preventative medicine? I presume staying up with vaccinations, getting your routine and preventative yearly health exams, but then with newborns and if where you can sort of, are there certain stages within pediatrics and you referenced child development. I must say and name the fact that you exude the joy when you talk about it. You smile and you're like, so you can definitely see that. And I think it's important for the audience to understand that folks are here because they're committed to this work and overall improving healthcare and the quality of life. And so what is pediatric preventative care? What does it include?
Yes. So during the earlier years, so between 0 and 3 years of age, children are seen more frequently than the annual visit that adults might be familiar with. So between zero and so usually children are seen in the newborn phase, right after they've left the nursery or the NICU, sort of monitor to make sure that their weight is improving. And then there's a 1 month checkup, a 2 month checkup, and then it's every 2 months. And then after the 6 month checkup, it's every 3 months until they're 18 months of age. And then it's every 6 months until they're 3 years old. And then it's yearly after that. So it's a lot more frequent in the earlier years because there's a lot of change and a lot of movement really in how much monitoring and adjusting needs to be done. So for example, one of the things we're definitely monitoring in the early stages is growth. So people are very familiar that the pediatrician will come out with a growth chart and was sort of monitoring the weight, monitoring the length, monitoring the head circumference in the first 2 years of life. And really we're trying to get these data points so that when we see a change in the trend, we can pick up on that. So whether it's weight loss or head circumference is changing, anything else that could tell us that something is going on, we really want to be able to capture that earlier rather than later. So that's one of the things we're doing a lot of monitoring the growth. And I think one thing to say about the growth chart is, yes, it sort of tells you where your child is compared to other children, but really we're monitoring the trajectory of your own child over time. And so if someone is at the 3rd percentile, as long as they're staying there, that is their self-regulated sort of trajectory.
And that gives a baseline basically. And that's why it's so important to go every year, because when you talk about the trends, if they're going for 2 years and all of a sudden something switches or drops, it's like, wait, we can look at the past 2 years. And so you all hear us refer to that term baseline often. That's why it's so important to get your blood tests and have your health screenings. Again, kind of light, but I need to ask this when you mention head circumference. There is also this rumor that, little boys' heads tend to be bigger than girls. And that's always been sort of this joke that, the guys, the males grow into their head. And so is that scientifically with the head? When you mention head circumference, I'm like, I have to ask this while I have a professional.
Well, I have to be honest, this is the first time I've heard this rumor, so I clearly did not get the memo. No, not necessarily. I think, no, for sure. I don't think so. I think just to make it clear, but definitely when we're seeing, and growth is monitored throughout the stages. So even during adolescence, we're monitoring the growth spurt that happens with puberty and all of those things. And one of the things we do is thinking about family factors. So this is where I want to mention a little bit of family history as well, the importance of how that impacts how we are caring for children. So we can look at maybe the parents' height and enter that, and then we can get a sense. A lot of kids will ask me, how tall will I be when I'm done growing, right? So we can use that data and find out, oh, this is the growth potential that you have. And if we're not meeting that, then we start to think what's going on, right? But again, it could be 1 or 2 inches off. So, but those are things that can be helpful too in thinking about growth. But I think,
family history is definitely important. I guess that's one of the processes from the mother transitioning from prenatal care, and now she's coming into the pediatrician. One of the things coming to the doctor's office to see your pediatrician is you ask about family history. What else can a parent expect? Because we can't presume everybody has a pediatrician, and I cannot reiterate that enough, that if your child has a pediatrician, you and that child are so much more better set up for prevention. Colds and things like that, just as children, we can't avoid. But what else can parents expect when they go into the doctor's office? Questions to be asked about family history and what else? Generally, sort of speaking.
Yeah, absolutely. So one of the things that are expected when you come to the pediatrician's office are questionnaires that you might have to fill out.
Mm-hmm.
So these are questions related to development of your child. There are also social determinants of health screenings that we do. As we know, children are not growing in isolation. They're part of a community, they're part of a family. And so really thinking about the well-being of the caretakers as well. So there's definitely screening for depression, for example, in the postpartum period. There's screening for resources. And then there's also the developmental screens with the questionnaire. So being prepared to either, with now electronic medical record systems, being able to sign up for the portal, for example, if that's available through your pediatrician's office, and taking the time to fill out those questions, because that really helps with also setting up the agenda. It's helpful when your doctor can look at those questions, what you've answered ahead of time, so that there's a way to focus. Again, there's a general template of sort of what the visit will be like, what we'll cover during a visit, but sometimes there's something that's important to you that you want to focus on. For example, you could come in and what you want to focus on at the 6-month visit is sleep for your child, and sort of trying to get them to sleep through the night and how that's impacting you. So questionnaires and being able to answer those maybe beforehand can really help guide the conversation. So expecting some questionnaires, expecting to be asked about daily routine. So thinking about nutrition, sleep, voiding, toileting, right? All of those questions will come up. In addition, also questions about family history will come up. I think one of the things that we might miss is those opportunities when we do talk to our family members, again, whether it's annual gatherings or over the holidays, catch up, find out what someone has been diagnosed with, because we are all connected and that impacts our health as well. So thinking about that, and that's something to review at the visits, is okay, this came up, this family member has this, and this is how it's connected to the child. So being able to share some of that information is key. Thinking about any medications that your child might have obtained from either urgent care visits or emergency visits. In addition, I wanted to share also the importance of writing down some questions beforehand, because again, things happen so quickly when you're in the visit, and our visits, again, we could spend a lot of time, but we do not have enough time for really the care that our patients need. And so being able to start off with some of the top of mind questions so that nothing is missed, and you don't feel that when the doctor's heading out of the room, you still have some questions.
Absolutely. The other thing that stood out when you were talking, and it's so important, and we can't, I say this all the time, that a parent can't answer a family history if they don't know their family history, if they don't know their baseline. And so it's so much more, not more, it's just as important, would you agree, that parents keep up with their care, as you referred to, at the family gathering, at the cookout during the summer, God forbid if there is an incident and a scare and folks have to gather at the hospital, that may be an opportune time to grab the elders and say, hey, what's going on? Because that adult needs to be informed about their health care to better inform you. And I also want to reiterate the piece of preparing, writing down questions. And so when you get that email or you get that link to fill out the form, it actually gives you more time as the provider, correct? If they go in with the information. And so these are little things that, while we know that there are issues in the healthcare system, there's some responsibility that we have to prepare as parents and getting ready to go into that visit. We are getting ready to go and talk a little bit more about a childhood disease that is often diagnosed in our children, Black and brown children, which is asthma. But before we transition into that, we're going to have Dr. Cuete back to answer general questions. But from your observation, being a Black woman working in a city and state that is well known for healthcare, are there disparities in pediatric care? We know in adult care, but are there disparities in pediatric care? And one would say, well, James, if the parents are dealing with disparities, so the children, and I saw that look. So let's go there. What are the disparities?
Yeah, so I think there are lots of disparities in pediatric care, as there is in medicine in general.
Yes. Yep.
And I think, as I mentioned and alluded to, children are not living in a bubble, right? I'd love them to come into the healthcare system as a blank slate, but they're not, right? And I think there's also the impact of compounded disparities, right? They've had parents who've gone through the prenatal period, they've gone through the delivery room, and all those. We do know the disparities within maternal health and perinatal health, and so they're coming into our offices with presumptions and experiences that we should be able to recognize. So definitely there are disparities as we think of opportunities to develop trust for the system, right? As a pediatrician, I'd love to think that I'm starting off with a clean slate, but I'm not with families. And so developing trust is really the challenge, and it's earned. And I know that pediatricians are one of the most trusted people, right? When we do surveys of people say they're pediatrician, they trust their pediatrician, but it's not a given. It's earned, and it's earned through continuity of care, right? Through those relationships and long-term connections.
I wanted to ask, and this is sort of off record, but again, I forewarned you that we're organic space. Has that trust changed a little bit by your experience with the pandemic and the vaccination? There's some unfortunate misinformation out there. And I just wanted to know, as a provider, have you noticed any change with any reservations with parents now, with pediatricians around regular childhood vaccinations? And we didn't talk a lot about it, but I'm sure the vaccination for COVID for children, have you seen an impact in any resistance to the regular measles, mumps, rubella, what's the other one? I'm trying to act like I remember all the medical terms. What's varicella?
Chickenpox.
Chickenpox.
Yeah, you have your 1 year vaccines down.
Oh, okay.
Yeah. I think that honestly, the COVID-19 pandemic has sort of been an impetus for us to have honest conversations around immunizations and vaccines. I think it's been an opportunity to ask for that education, that back and forth, and have honest conversations. I think parents will say, I'm not ready yet, I'm still thinking about it, and I'll be able to provide information. And again, thinking about the challenges with ensuring that we have information in different languages. I care for a very multicultural patient population, and it's so important to have information in people's preferred language so that they make an informed decision. So as a pediatrician, we are here to help families make an informed decision. And there's a lot of misinformation, and there's a lot of sources of information that our patients might be seeing and receiving. And so it's so important to have that space, to have those conversations and honestly say, what have you heard? What do you think? And how can I be helpful? Do you need more information? And really have that conversation. So I think it's been a challenge, but I think it's teaching us a lot of how we can do better.
One of the things I wanted to ask you about, we're going to getting ready to bring in Dr. James, but the percentage of patients off the top of your head, Black and brown, when it comes to respiratory asthma type diseases, is that still a large diagnosis for a lot of our children? And it's funny because, and I'm not a medical person, but I used to say that asthma was hereditary by environment, maybe not necessarily, and you can correct me, but if it's hereditary by, DNA, it doesn't help if the environment perpetuates, these things. And so a little transition into asthma as we get ready to bring in Dr. James. From your general pediatrician perspective, where are we with childhood, a very common childhood disease among Black and brown children of asthma?
Yeah, so I think definitely do see asthma. And I think one of the things that comes up as well with sort of thinking of where asthma fits into the pathology of disease, we're thinking of asthma being responsive airways, where you have irritable airways, right? You get wheezing and all of those symptoms when you get irritants into your respiratory system. Well, that's also connected with eczema, right? Of your skin being really sensitive to things, right? And that's also connected with allergic rhinitis, so hay fever, with sort of you get itchy eyes and all of that. And also thinking of food allergies, right? So that's your GI tract that's really sensitive. So we call that the triad of atopy. So we're thinking asthma, eczema, and allergic rhinitis. So again, when thinking of that family history, right, someone might have really bad eczema and somebody else has some food allergies, really bad seasonal allergies, and sort of bringing all that together. I think even so right now, I think continuing to think of how that impacts families. And so being able to, whenever we ask a history, anyone with asthma in the family, and they'll say no, and then you say anyone with eczema, and that's, oh, I had really bad eczema, right? And it could be an immediate caregiver, right? So I think it's having those conversations. And then I think related to continuity of care, asthma can be hard to nail down, right? Oh, I had once upon a time, my child had wheezing, and then they went to the urgent care, they did some breathing treatment, got better. Well, you do need continuity of care, right? So you need someone to have seen your child a few times and said, well, that winter you needed albuterol. This winter you needed albuterol. So I think there's a pattern here. You have reactive airway disease or asthma, right? So preventive care is really important to piece it all together rather than fragmented care going to one ED, one urgent care where people might not be able to put it all together.
Absolutely. We're going to transition and bring in our Dr. James. Dr. Cuete is going to stick with us in the background. We're going to bring in Dr. James and further this conversation. And thank you so much, because I never heard in a medical setting of correlating the hay fever, the eczema, and the asthma together. So we can go a little bit either further into that or more. But Dr. Cuete will be back with us in just about 15, 20 minutes. And we're going to talk to Dr. James a little bit more about asthma. Thank you so much, Dr. Cuete. We'll see you in a few minutes. Dr. James, our veteran. And so I know you were in the background listening. We've talked about a few of these subjects before. And so are you still seeing presumably a disproportionate amount of diagnosis of Black and brown children with asthma and or eczema, or I forgot the medical term for hay fever, which I've never heard that before.
Like, so allergies,
yes,
seasonal allergies.
Yeah. So is it still going on? It
is still going on. So we know that Black children are 1.5 times as likely to have asthma compared to white children. Puerto Rican children are 2 times as likely, and it's sort of similar numbers for Native American children. So Black and brown kids certainly have a higher risk of asthma. And I think it's so important that you brought up this idea of like genetic factors and environmental factors. So we do know that there is a genetic component that puts you at a risk for asthma, but really what's causing this disproportionate number of children, Black and brown children having asthma, is because of the environment and because of how systemic racism have put Black and brown people into less healthy environments, because the real triggers for asthma are pollution in the air, mold, rodents. So, with things like redlining and lack of wealth and forcing sort of Black and brown communities into less healthy environments, that certainly has increased asthma in those populations.
It's so interesting when you talk about the housing piece and you were naming some of the contributors to airway and respiratory type diseases, rodents, roaches, and things like that. Those all, and unfortunately, as you mentioned, due to the economy, poverty, and different things like that, Black and brown people tend to experience living in environments where those things are prevalent, very much so. But then there's also sort of the macro environment as well. And so when I think about it, it was a thought I had, I think, sitting in a public health workshop some years ago, that while to some extent it may be genetic, it doesn't help if you're living in an environment with those other determinants. And so let me ask a very basic question. What is asthma? What is it?
So I love talking about asthma. It's something I'm passionate about because growing up, my sister had very severe asthma, and now I get to take care of it, take care of kids and adults that have asthma. So asthma is a chronic disease, meaning it's like a disease that can last for years or sometimes a whole lifetime, where you have inflammation or sort of like swelling in your lungs, and more reactive, meaning like more sensitive lungs, that makes it harder to breathe. And so it's harder to breathe because the lungs can be swollen, and then also because something can happen called bronchospasm, which is basically the lungs are a little bit overreactive and they squeeze shut. It makes it harder for you to breathe. And so that the treatments for asthma address both the inflammation, the swelling, and the bronchospasm, the squeezing shut.
Okay, and the bronchial, again, y'all know I got a little bit of medical experience. So the bronchial, when people talk about bronchitis, that's the inflammation of the bronchi, the things
Yes.
that filter, I think, to an extent. Go ahead, you're the doctor.
So lungs are kind of like a sponge.
Yep.
But instead of instead of your sponge is full of water, your lungs are full of air. And so the big airway here from like your throat down, that's called the trachea. Then
Okay.
it branches off into two lines, and those are your bronchus. So that's bronchitis is inflammation of those
Upper
branches.
and that's an
But
upper
then when it goes
respiratory.
down into the throughout the lungs, and they're super, super tiny, those are called bronchioles.
Okay.
So they're just trachea, bronchi, bronchioles.
Let's
And
go.
in asthma, those can squeeze shut and can be swollen.
Okay.
And things that trigger that to happen, like triggering them to squeeze shut, are things like a cold, exposure to molds, exposure to an allergen.
So Dr. Cuete mentioned, and I lost my train of thought because there are so many, but she mentioned that, you have to be followed by a doctor. And sometimes, there may be an allergy that causes those three areas to react. And it may just be induced or caused by that allergy, and that may not be asthma. How can someone let me correct that. I don't even want to say that. How does someone determine that they may have asthma? They may be symptomatic. And if where you can, in a post-COVID period that attacks the respiratory system, I'm sure your work has been very interesting in the last couple of years.
So I'd say, so if you're like, I think maybe I have asthma, or maybe my child has asthma, the symptoms of asthma can be wheezing, which is like the sound. So sometimes you can hear that when you're breathing or your child is breathing, but sometimes the wheezing can only be heard by a stethoscope. And so that's why it's really important to go to the doctors and have, your doctor listening to your child's lungs. I just actually diagnosed wheezing the other day in my office. The other symptom can
I ask one question?
Coughing. Sorry, go ahead.
Ask a question about the wheezing for clarity. Wheezing often, and again, unfortunately, growing up in the environment I grew up in, a lot of people had asthma. You heard wheezing all the time and albuterol and things. And so, but there is a wheeze that is not able to be heard for lack of better words, naked ear without the stethoscope.
Exactly. So truthfully, if you can hear wheezing like without a stethoscope, that's pretty severe, actually.
Okay.
So like at that point, if you can hear wheezing without a stethoscope, you definitely need to be treated.
Okay.
But sometimes when the asthma hasn't gotten that severe yet, we can hear it with our stethoscope. And then the other symptom is sometimes you won't hear wheezing, but having frequent cough. So especially cough at night, or it's like, oh, I have a cold and my friend has a cold, but like I'm coughing so much with this cold and my friend's only coughing a little bit. Sometimes that can be a symptom, but you really need to go see the doctor to be able to differentiate, like, is this just a cough from a cold, or is this a cold plus it's worse because there's asthma there?
Wow. And if you can touch on a little bit post-COVID, well, not post, but a lot of people had COVID. How are you guys evaluating, or is it the same way, evaluating sort of a long COVID impact that may subside versus asthma? And can asthma be temporary?
So I would say, luckily, we were very, very worried that COVID was going to really disproportionately make people with asthma so much more sick. For some reason, that hasn't totally been the case. it is very true that some people with asthma, when they get COVID, it causes an asthma attack. And so then they're going to need to be treated for their asthma attack. But luckily, children with asthma haven't seemed to be, more negatively affected by COVID, which is great. And yes, so asthma you can outgrow asthma. So many young children will have asthma. And part of that is because, their bronchioles and bronchi are smaller. And their bodies are still developing. And so they may only have asthma in young childhood, and then will grow out of it as they become teenagers and adults. But a portion of those people will continue to have asthma their whole life. So I would say some do grow out of it, or some they'll have it their whole life. Many, even if they have it their whole life, though, it can become less severe as you get older, which is a good thing.
As you were saying that, I was thinking about one of my cousins, and when you talk about that loud, audible wheezing, I remember like hearing it often. That we'd be playing, and she'd sit down, and that's what wheezing to. I'll admit, back in my teen years, I was trying to get out of work early, and I told occupational health that I was wheezing. She said, "Well, let me hear you wheeze." I was like, what do you mean? I'm wheezing. That's all you need to know. But I have heard that sound before, unfortunately. We're going to get ready to bring in Dr. Cuete. And I think a lot of our parents attending to their children today. And we may not have as many questions. We do have a lot of non-children in here with questions. And so again, I wanted to mention that definitely the adults, you all have not been examined, but generally where both of these well-informed physicians can give some general information. Let me just look for some questions here. We may or may not have them. I just wanted to mention one thing. We are having an air quality summit on March 9th from 5 to 8 at East Boston High School, focusing on asthma and air quality. And so those type of things are not just going to the doctor, but also being aware and participating in events like that can contribute to a better environment. I see a lot of comments where folks have, talked about being on prednisone. Leslie said prednisone was my friend. She also takes Zyrtec daily. And as well as I had, you did give the, rapid airway disease.
Reactive airway.
Reactive. I knew it was somewhere in there. And so you referenced to that as well. And here's a point that, parents and Heidi's not a PD patient anymore, but if any senior is watching or watch this after, it's important. And in our community, we tend not to always divulge everything, especially if it's an active diagnosis or whatever. We don't want to worry the family, but it is important, older and elder family members, senior members, to ensure that you share your health information with your family, because if one of these doctors are asking about family history and you haven't revealed that you, your grandmother, and your aunt both had something, it could be an issue for your child. So I don't see as many questions.
I did want to make a comment about the prednisone. So, so for the treatments for asthma, there are, there's two different types. One that it focuses on decreasing that swelling, that inflammation. And so prednisone is one of those medicines. It's called a steroid, and it decreases inflammation. Now, when you need to take prednisone, that's usually a pill. And so that is going to get to your lungs, but it also can affect all of your body. And there are some side effects to it. It can make your blood sugar higher. It can cause like edema, swelling in your lower legs. It's not super great for your heart. So one of the things we try to do is treat earlier with inhaled steroids. So like an inhaler that has that prednisone in it. And then it only goes to your lungs and it doesn't affect the whole body. And so oftentimes, being able to do those inhalers earlier can help prevent the need to use prednisone. Sometimes you're still going to need to use the prednisone, but that's another reason that it's good to be going to your pediatrician regularly so they can sort of monitor, get you on those preventative inhalers to help avoid needing to use prednisone if at all possible.
That's one of the things I forgot to ask about, and Dr. Cuete jump in here as well. But Nicole is saying that her daughter is on Flovent twice a day. And so both of you are like, yes. And so is that a popular treatment for asthma, allergy, eczema? Is that, Dr. Cuete, is that why I saw you really shake your head?
Yes, it is.
Popular is okay.
Yeah. So one thing that always comes up sometimes in visits is the question of, so as Dr. James mentioned, asthma is a chronic illness, right? Which usually means that we want to keep it at bay. So it usually means that then you're taking a medication every day. So in the case of asthma, that can be Flovent, which is an inhaled steroid, and that's always given with the spacer. So all inhalers should be administered with the spacer, which is sort of this is a tubular. This is sort of
I should have grabbed one from my office.
That's not the
it's like a cylindrical device that you attach to the inhaler and then spray it. And it's really important to use the spacer because that's what aerosolizes the medication so that it goes only to the lungs. If you use an inhaler without a spacer, then you're just administering the medication to the back of your throat. So it's not actually getting to the lungs. So a spacer is very important to use with the inhaler. So making sure that when your child is on Flovent, yes, that's amazing drawing, Dr. James.
Look, I'm trying to find find a picture myself. So let me see the drawing because I was on the screen. Let me see. Oh, Dr. James, you're multi-talented, but since I did the research, let me also put this one up here because it's important for folks to know all of that. And when they see these things, it's not, uncommon to them. And so this is what a spacer, in addition to what Dr. James shared with us, that's
much better
what a spacer looks like. And so I've seen those before. And for some reason, it's not the what is the peak flow monitor? Because when you first mentioned that, I'm thinking of the peak flow that's blowing into. This is your inhaling, and Dr. James is about to give us a peak flow monitor picture.
No, I think a peak flow is more of like a test that you can use at home to see like how good your lungs are working.
Okay.
Whereas the spacer is like the special tool to help get that medicine into your lungs rather than in your mouth.
Okay.
Yeah.
Go ahead, Dr. Cuete.
So I think the other thing to mention with the Flovent, for example, is definitely following up with your pediatrician. And sometimes what is done is we might notice that people's asthma might be worse in the winter time. So maybe the plan would be to be on Flovent for the winter. And then in the summertime, when things seem better, you might be off that medication, but then follow up with the doctor. And one of the things that we do when a child has a diagnosis of asthma is part of the questionnaires that might come up for your well-child visit with your doctor will be what we call the asthma control test. So that is basically a questionnaire regarding symptoms of asthma. So that means how often are you using Albuterol per week, which is the rescue inhaler? How many times is your child waking up in the middle of the night because of a cough? How much can your child keep up with other kids with running around and playing? So that way we can get a sense of how good are we controlling things, or do we need to make adjustments? So those again are things that I cannot stress how important it is to kind of have time to sit down and review questionnaires, as they definitely impact the trajectory of care.
Absolutely. I wanted to ask one question in relation to one of the ways that asthma is treated, and that is with Albuterol. And Nicole, when she shared this, my first thought is that Albuterol, because Albuterol, I've had to take it before having pneumonia, you know what I mean, temporarily. And so I remember hearing that. And Nicole, can you let us know what medication that is exactly that's giving her the shakes? But that was my first thought, because Albuterol has, if I'm remember correctly, has been, is it a stimulant? What? Because I've heard this before about Albuterol. Dr. James.
So Albuterol Flovent is a medicine that helps address that inflammation that we talked about, and Albuterol helps address that spasm, so that the squeezing shut of the bronchioles. And it's a beta agonist, so which is the way it works. And so it works on these beta cells that cause the muscles to squeeze shut.
Yep.
And so then it helps relax them. However, one of the side effects of Albuterol is it can make your heart rate a little bit faster.
Yep.
And so that sometimes people will feel a little bit jittery or shaky with the Albuterol.
Yeah.
And so, but it is an important medicine because it is opening up the lungs, but that's another reason why we utilize medicines like Flovent, because hopefully if you have the Flovent on board and the inflammation goes down, then you won't, then even if the bronchial spasm a little bit, because there's less inflammation, they won't spasm all the way shut. And so hopefully you need to use the albuterol less often.
Okay.
But sometimes if it's a bad asthma attack, you still need it.
Okay. Is there anything, Dr. Cuete, Dr. James, that we missed in relation to is there anything, Dr. Cuete, that right now you're seeing a trend that we need to sound our alarm for people to be cognizant of? I remember a few months ago, they were saying that there was a little uptick in the measles and things like that. Is there anything from a public health perspective that you're seeing that parents should just really keep an ear out for?
I think one thing I wanted to share definitely with sort of school vacation week is really just having a review at the start of the year, right? Of if your child has their annual physical scheduled or their next appointment with a doctor scheduled. Because I know that with the COVID-19 pandemic, there's a lot of appointments that might have been pushed down the line or canceled because of the situation we're in with limiting access to in-person visits. And so maybe some other well-child checks might have been as virtual appointments. So making sure, again, that we are scheduling in-person appointments, catching back up with vaccinations or immunizations or just general visits to the doctor. So I think that's always one thing. I think vacation weeks are great because then children don't have to miss school or can come in for their checkup or blood work. Because sometimes some of them might be fasting, so it might be easier to do it during vacation, so that you're not fasting during the day. You can come right in the morning and not miss school.
Yeah, because trying to have the kids fast to take that CBC and that blood test. I remember a few parents growing up where I grew up, and we lived in Bromley Heath housing projects. And I remember one mother yelling one day, coming in the hall, got all the way there to the hospital, and she went, and I think she drank water or something, and they told her that, she couldn't do the fasting test or whatever. But yes, during vacation, so they don't have to miss school, schedule those tests. Dr. James, was there anything that we missed that you wanted to share?
Well, I would say you can drink water for fasting, but nothing else. No juice, no coffee, all this. Okay. But I was going to say, I think you had some guests on a little while before about the triple-demic. So that we were having COVID and RSV and flu. And so those are all respiratory viruses. And so I did say that it is good that it doesn't seem like COVID's making kids with asthma at too much of an increased risk, but any respiratory virus, flu, RSV, COVID, can cause asthma attacks. So just, again, an important reason to be checking in with your doctor to see if your child needs any adjustments to their inhalers. And I did see that someone commented on their child having severe asthma. And I would say that as pediatricians, we do have a lot of expertise in asthma, but sometimes if a child is having a lot of asthma attacks, is needing prednisone a lot, you should be asking your doctor to see a pulmonologist. So a pediatrician that all they do is focus on the lung, because there are some more advanced treatments out there that are available that can help keep your kids healthier. Okay.
Dr. James and Dr. Cuete, thank both of you again. I think a lot of our parents are tending to these kids, so to their children this morning, and so not as many questions, but in the after, if I notice any major questions, I'll make sure we get them to you and figure out how to get the answers back to the parents that watch the after watch. I'm going to let both of you go. I'm going to go pay some bills, share our topic for 2 weeks from, for the first Tuesday in March. Thank both of you. Dr. James, at some point when we have to do your healthy Java, if I'm not available, you might be the one that, because you're just a veteran now, we'll just send you a cheat sheet of the tech and you can just run it, you and Dr. Alabre. But thank both of you. And again, mentioning Dr. Alabre. Dr. Alabre is not on screen as much, but thank you so much, Dr. Alabre, for making these connections to these great physicians, that getting the information out in a layman's presentation is so important. So thank both of you. I appreciate you.
Yes, thanks for having us.
Absolutely. Thank both of you again. We're going to share with you that on March 7th, we are going to discuss renal disease and kidney failure. A few months ago, Cindy and Dr. Alabre and I in this space live asked you all to put your subjects, your desired subjects in the comments, and we did that. And so, and Cindy, I have the sheet open since you're watching. And I can tell you that out of high blood pressure, pediatrics, aging parents, renal failure, arthritis, dementia, lupus, bone density and osteoporosis, and weight control, we're and eye health, we're covering all that you asked. And so on March 7th, we are going to have a world-renowned doctor, Dr. Nguyen, who will be with us talking about renal disease and kidney failure. And I believe that it was it. Shamika, good morning. Thank you. Leslie, thank you as well. Sharon Cornelius, good morning. Next week is vacation for interesting. They have a different week. Cindy, thank you so much. I have a form of asthma due to allergies, bleach, and cigarettes. Wow. Okay. So folks, don't forget on the first Tuesday in March, also for the 6 of you that are in here this morning, I don't know where these parents are at. Please do me a favor, and we're going to go ahead and get that information out on Facebook and Twitter as well. This is in, it should have been pinned in the comments. I forgot to do it. I'm going to do it right now. If you go to the top of the comments, I am going to ask you to do me a favor and let me know how we're doing with your Healthy Java. The time of day, the topics that we're covering. I want to hear from you all how we can make healthy your Healthy Java even more better. Let me now, how do I go in these comments? Okay, I got to turn the sound down. All right, now how do I pin the comment, Jesus? It won't let me do it. Okay. Sorry, guys. It's not letting me. It's only letting me. I can't see the comment. But if you go all the way up to the top in the comments, the link for the survey is there. And we want to hear from you. So please go fill out the survey. It'll be up until March 7th. At the end of that show, we will close the survey. So it'll be up for 2 weeks. I haven't decided yet that if you do the survey, whether you'll automatically be entered into a drawing to receive a $50 gift card. I don't know. But fill out the survey. And if we do that, you'll get an email to let you know that you've been entered. All right. Tomorrow morning, Wednesday. No, I was going to say November, February 22nd. When we talk about healthcare and disparities, wealth and where we live and our living environment is a huge part of that. And so I wanted to let you all know that, and this is the wrong one. I wanted to let you all know that tomorrow at 9 a.m., I have the wonderful privilege and opportunity to bring 2 folks that I recently started working with around closing the wealth gap among Black and Brown residents here in Boston and in Massachusetts. And so for We Need to Know Wednesdays, tomorrow, February 22nd at 9 a.m., we're going to talk with Realtor Eric Lindsay and also attorney Jordana Greenman, closing the wealth gap through home ownership. That is taking place tomorrow morning at 9 a.m. Yours truly has the wonderful opportunity to be the host for their fun, informative event taking place on March 11th. It's almost like a home ownership 101 in one day. I don't think you'll get a certificate from it, but it's a fun event. I believe there's going to be a DJ there. I'm your host and MC for the day. It's at Venencia's. If you don't know what Venencia's is, look it up. You do have to register. We'll have that information available for you tomorrow. Thank you all for tuning in today. And we will see you tomorrow morning at 9 a.m. Have a great day, everybody, and we shall talk to you soon. I'm just